All right, let's talk about fundamentals of nursing for the NCLEX. When you hear that phrase, what's the first thing you think of? Be honest. Is it making beds? Giving baths? Yeah, if that's where your head's at, you're definitely not alone. But we are about to completely flip that idea on its head.
I mean, let's just get real for a second. For so many students, fundamentals feels like this long, kind of boring list of basic tasks you just have to memorize. But if that's all we see, we're missing the entire point, and the single most important skill the NCLEX is actually designed to test. So here's the secret. Fundamentals isn't about tasks at all. Think of it as your nursing operating system. Seriously, it's not about memorizing what to do, it's about installing the core software for how to think. This is the foundation for your clinical judgment, your decision-making, and above all, patient safety. All that other stuff you study, med-surg, peds, they're just apps running on this one core system. And what's the prime directive of that operating system? It's a big word, non-maleficence. But don't let it scare you. It just means one simple, incredibly powerful thing. Do no harm. That's it. Every single safety rule, every time you double-check a med, all those frameworks you learn, they're all there to make sure you stick to that one critical duty. Okay, so if fundamentals is all about learning how to think, then what's the main tool in your toolbox? Well, it's this really systematic process that's going to guide literally every single thing you do as a nurse. And boom, here it is, the nursing process. Now look closely. This is not a straight line, right? It's not just some simple checklist you run through once. It's a loop. It's continuous. It's dynamic. You're always thinking and rethinking because your patient's condition is always changing. We all know the acronym, right? ADPIE. Super simple. You assess, that's gathering your data. You make a nursing diagnosis. You plan your goals, you implement your actions, and then, this is key, you evaluate the results. This little 5-step process, it's the absolute cornerstone of everything we do in nursing. Now, out of all of those steps, there is one that the NCLEX will drill into your head over and over and over again, and that's assessment. Assessment is the bedrock. Why? Because acting without enough information is the fastest way to make a mistake. So before you do anything, just stop and ask yourself, do I really have enough information here? If the answer is no, or even maybe, your next step is always to get more data. But here's a really important distinction. Just gathering the data isn't enough. You have to understand it. Think of it like a puzzle. Assessment is you just collecting all the pieces, the vitals, the lab results, what the patient's telling you. But analysis, that's when you start putting those pieces together to actually see the picture. That's where you recognize the important clues and figure out what's really going on. Okay, so how does this actually show up on the NCLEX? I mean, how do they test this? Well, it all comes down to one thing, your ability to prioritize safely. You're going to see so many questions that ask, what do you do first? And your go-to, your default answer should almost always be to assess. But, and this is a huge but, there is one massive exception. If you see an immediate, life-threatening problem with your patient's airway, breathing, or circulation, the ABCs, you have to intervene. Right then. That is the only time you jump straight to action before getting more info. This actually leads us right into another huge safety rule. Always start with the least invasive option. Offer a warm blanket before you offer a pill. Try repositioning someone before you even think about restraints. It's about starting with the simplest, safest thing you can possibly do that still makes sense for the situation. All right, another big one they test in fundamentals is delegation. And look, this isn't just about pawning off your work. No way. It's a professional judgment call. And the most critical piece of this is that even when you delegate a task, you, the RN, are still 100% accountable for what happens to that patient. Let's make that super clear. Say you ask an aide to get a set of vitals. They are responsible for doing it correctly. But you, the RN, are accountable for looking at those numbers and realizing, whoa, that blood pressure is dangerously low, and then figuring out what to do about it. See the difference? You can hand off the task, but you can never hand off the final accountability. So, what can't you delegate? Well, here's a super handy rule of thumb. If you have to eat it, you can't delegate it. EAT stands for evaluate, assess, or teach. Anything that involves that core nursing process, any kind of initial or tricky patient education, or care for an unstable patient, nope, That stays with the RN, period. Okay, so we've got our mental toolkit. Now let's talk about the common traps the NCLEX sets. And just to be clear, these aren't meant to be gotcha questions. They're designed specifically to check if your nursing operating system is running the way it should be. Trap number 1 is the biggest one of all, rushing to intervene. You see something wrong and your gut reaction is, I gotta fix this, now. But that's exactly what the NCLEX is testing. It wants to see if you have the discipline to pause, get the facts, and then make a safe call. It all comes back to that assess first rule we talked about. Trap number 2 is forgetting the absolute basics of safety. These are the simple things that are so easy to forget but can have massive consequences. We're talking about things like keeping the head of the bed up for aspiration risk, making sure the bed is low and the call light is right there to prevent falls, and of course the absolute number 1 thing, hand hygiene. These are non-negotiable. Oh, and here's a classic trap, confusing clean versus sterile. It sounds simple, but it trips people up. Clean technique is just about reducing the number of germs, like when you're giving meds. But sterile technique? That's about eliminating all of them. Think inserting a Foley catheter. You get those mixed up and you're putting your patient at a huge risk for infection. Trap number 4 is a big one, ignoring trends. A single number by itself can lie to you. A blood pressure of 120/80 sounds perfect, right? But what if an hour ago it was 180/100? Now that's a totally different story. The NCLEX wants to know if you can see the pattern. A slow drop in urine output, a temp that's creeping up, those trends are the critical clues. All right, let's pull all this together. Why do we hammer on these fundamentals so hard? Because honestly, this is about so much more than just passing a test. Once you really truly master this nursing operating system, I promise you, every other subject gets easier. Med-surg, peds, all of it. Because you'll already have the mental framework to think through any problem that comes your way. This is the foundation that your entire nursing career is going to be built on. So if you take one thing away from this, let it be this. Stop thinking of fundamentals as just the basics or some boring class you have to get through. Start seeing it for what it actually is. It's the course that teaches you how to think. It's where you learn to be a safe, effective, and confident nurse. And I'll leave you with this question to take with you. The very next time you're faced with a clinical scenario, whether it's in a practice question or on the floor, what's the first thing you're going to assess? What piece of information do you need to make sure your next move is a safe one? Welcome. Okay, let's dive straight into this explainer. We're looking at the journey from the idealistic inner compass of nursing ethics all the way to the hard, pragmatic boundaries of medical law. You know, it's this fascinating intersection where human compassion actually meets strict regulation. And getting a handle on this, it's absolutely crucial, not just for passing your exams, but for protecting your license and your patients every single day. So here's our roadmap for today. We'll hit the 6 ethical principles, malpractice and intentional torts, consent and advance directives, the rules of documentation, and finally, privacy and mandatory reporting. All right, moving to section 1, the 6 ethical principles. We're starting out on the moral stage to really explore that fundamental framework guiding every single nursing decision. There's a handy little mnemonic we use for this, JMBFV. Look, I know it doesn't exactly roll off the tongue, right? But it's actually a super effective memory aid to lock these 6 critical ethical pillars into your mind. Let's walk through what each of these powerful words literally looks like in practice. First up is autonomy, which is really all about respecting choices. As a nurse, you are advocating for the patient's autonomous decision, even if it totally conflicts with what the medical team wants. Like if a competent adult patient refuses a life-saving blood transfusion for personal or religious reasons, you absolutely must legally and ethically honor that choice. You know, you educate them on the consequences, for sure, but you never, ever force treatment. Next is beneficence, the duty to simply do good. And this actually reveals a really fascinating balance you have to strike. Doing good is vital, but it can never override a competent adult's autonomy. So if taking extra time to make a dressing change less painful is beneficence, well, letting them refuse that dressing change entirely is autonomy. Autonomy is always going to take precedence. Okay, let's move to non-maleficence and see how this builds into everyday safety particles. This is the classic, first, do no harm. Think about the absolute necessity of double-checking medication dosages to prevent an accidental overdose, or, just making sure the side rails are up for a fall risk patient. Whenever you're in doubt, preventing harm is your top priority.
Then we have justice. This just means acting impartially and equitably. Picture an emergency room nurse in a disastrous scenario. Justice dictates that you triage and treat the sickest patients first, regardless of who they are, their background, or their bank account. It's all about clinical need, period. Fidelity is all about loyalty and trust. It's that simple but profoundly impactful act of returning to a room in exactly 30 minutes to reassess pain just because you promised the patient you would. If you say you're going to do something, you follow through. That literally builds the whole foundation of the nurse-patient relationship. Finally, veracity. This is the principle of telling the absolute truth. Now, a massive NCLEX pitfall is thinking you should withhold a terminal diagnosis to practice beneficence and, spare patients' feelings. Actually, scratch that. That's completely incorrect. Veracity dictates they always have a right to the honest, accurate truth so they can make fully informed choices.
Moving on to Section 2, Malpractice and Intentional Torts. Let's transition from that internal ethical compass to the strict external legal boundaries that dictate what happens when things go wrong in healthcare.
Let's look at intentional torts. Just remember the memory aid A before B. Assault comes first. That's the verbal threat of an unwanted injection or treatment. Battery is the second step, which is actually carrying out that unauthorized physical act. So, tackling a combative patient and injecting them without consent or a proper chemical restraint order, that isn't just bad practice, it is literally battery.
Now, what about professional negligence or malpractice? For a malpractice lawsuit to actually stick, all 4 of these Ds have to be proven. You had a duty, there was a dereliction of that duty, it was the direct cause of injury, and there were actual damages. Meaning, a simple mistake, like, say, pulling the wrong dose but catching it before administration, resulting in 0 harm, well, that's a near miss. It's definitely an error, but without damages, it is not legal malpractice.
Section 3, Consent and Advance Directives. Let's pivot to see how patient autonomy manifests in the real world through legally binding consent and future planning directives. So, what's your specific role as a nurse here? It's totally key. Obtaining informed consent is the provider's job. They're the ones explaining the risks and alternatives. You are the witness and the advocate. That means if a patient is about to sign the form but says, "Actually, I don't really know why I need this surgery," you must halt the process immediately and call the surgeon. You don't try to explain all those complex medical details yourself. It's also super important to recognize the distinction between these advanced directives. Basically, these documents speak for the patient when they no longer can. A living will dictates the what, like whether they want CPR or a feeding tube. A durable power of attorney legally designates the who, the specific proxy or agent appointed to actually make those choices. Both of these honor the patient's autonomy ahead of time. All right, Section 4, the rules of documentation. Now we're entering the protective shield phase of our explainer, focusing on the daily habits that defend both the patient's record and your professional license. If it wasn't documented, it wasn't done. This is the absolute golden rule of nursing risk management. In a court of law, a blank space in a chart equals a total lack of care. A complete, perfectly accurate chart is your absolute best defense against a malpractice claim, while gaps and sloppy charting, those are going to be used to completely undermine your credibility. When you document, you've got to keep it factual. Avoid subjective labels like, "the patient is angry." That's just an assumption, right? Instead, stick to objective, observable facts. Write down, "patient is speaking loudly and face is flushed," or use their direct quotes. And hey, if you forget something, make a late entry following the proper policy. Never backdate, never chart in advance, and never, ever use whiteout. Seriously. Section 5, Privacy and Mandatory Reporting. For our final section today, we're going to explore the severe legal tension between fiercely protecting a patient's secrets and knowing exactly when the law actually forces you to speak up. The absolute bedrock of privacy is HIPAA. You've got to remember that simply confirming to a neighbor that someone is a patient in your facility, that is a direct violation without explicit consent. Venting on social media, even if you don't use names, is incredibly risky, and snooping in the chart of a patient you aren't directly caring for, even a friend's relative or some local celebrity, that leaves a digital audit trail and is a serious, fireable offense. But privacy and loyalty, they definitely have hard limits. Imagine you're right in the middle of a crazy busy shift and you encounter this ethical nightmare.
a coworker acting super drowsy with slurred speech, and maybe you smell alcohol. Keeping quiet just isn't an option here, so what is your exact next move?
The answer really highlights your professional mandate. Patient safety always, always trumps coworker loyalty. The only correct action is to escalate this immediately to a nursing supervisor so that nurse can be safely removed from care. Honestly, failing to report this implicates you both ethically through a failure of non-maleficence and legally.
Now, there are times when HIPAA takes a backseat to public safety. These are the mandatory reporting exceptions. If you see signs of child or elder abuse, you are legally obligated to report your suspicion. You don't need hard proof, and you definitely don't wait around to observe further. Good faith reporting is legally protected. The same whole thing goes for tracking serious communicable diseases to protect the community. The greater good simply overrides standard patient confidentiality.
So, as we wrap up this explainer, I really want you to reflect on the immense weight of the nursing license. You're tasked with holding the line between these rigid legal boundaries and unwavering human compassion. Are you prepared to step into the clinical setting and seamlessly balance justice, autonomy, and the strict letter of the law? Keep these principles close, and they will absolutely never lead you astray. Welcome, future nurses. Let's get right to it. In this explainer, we're taking charting from that tedious end-of-shift chore and transforming it into your absolute legal shield. Whether you're grinding through NCLEX prep or you're stepping on the floor with that brand new license, mastering how to document accurately is just absolutely crucial for your career.
So ask yourself this: is your charting actually protecting your patient, or is it risking your license? See, the high-stakes reality here is that nursing notes aren't just some personal memory aid. They are legally binding documents. We're talking insurance companies, state health inspectors, and yes, even the legal system looking at them. If your documentation is sloppy, you are vulnerable.
Okay, Section 1, the Golden Rules. Let's dive right into the foundational stuff. To make sure there's continuity of care and to protect yourself from liability, every single entry in your chart has to follow these 6 golden rules. Your charting must be objective, factual, accurate, timely, relevant, and patient-centered. Remember, you're not reading a novel here. You just want to document your actual assessment findings, the nursing interventions, how the patient responded, provider notifications, refusals of care, and any major changes in their condition. Just stick strictly to the facts. Now, let's break down the 2 main types of data you're going to be recording. On one hand, you've got objective data. This is the stuff you can observe and measure, right? Think vital signs, lab results, or physically seeing a patient grimacing. On the other hand, you have subjective data, which is whatever the patient says or feels. There's a really fun, easy trick from our source material for this called the cool chicken trick. It goes like this. Objective is observed, and subjective is what the patient says. Subjective data perfectly captures how a patient is actually feeling. And whenever a patient expresses this, you should always use their direct quotes rather than inserting your own clinical assumptions. So instead of writing something vague like, patient is nauseous, you write, the patient stated, I am feeling very nauseous. Doing it this way leaves absolutely zero room for misinterpretation by the nurse taking over on the next shift. All right, moving on to Section 2, structuring your notes. The big thing here is knowing how to translate those rules we just talked about into actual, readable notes. First up is the SOAPI method. This is a highly logical, chronological, step-by-step narrative for documenting care. It stands for subjective statements from the patient, objective measurable data like heart rate, assessment, which is your analysis of what's happening, the plan or treatment strategy, interventions, meaning the physical actions you took, and finally, evaluation of the patient's outcomes. Honestly, it's just a fantastic tool for comprehensive documentation. Now contrast SOAPI with DAR. DAR is a bit more fast-paced. It gets right to the point, which is exactly what you need when you're juggling multiple patients. It focuses strictly on the data you collected, both subjective and objective, the action you took in response, and the patient's response to that intervention. It's concise, it's effective, and it keeps your charting super focused. Let's jump into Section 3, Master the S-bar. Let's shift gears from written documentation to verbal reporting. When you need to call a physician or hand off a patient, you use the SBAR framework. SBAR stands for Situation, Background, Assessment, and Recommendation. Basically, it's a framework designed to cut out all the fluff and clearly communicate the absolute most important clinical info. When a patient is deteriorating, you do not have time to ramble. SBAR keeps you perfectly organized so you avoid that dreaded moment where a doctor asks you a question and you just freeze. Let's see exactly how this works in a high-energy urgent scenario. Imagine your patient's blood pressure just dropped significantly. You start with the situation. BP is 85/46. Give the background. They're 2 hours post-spinal surgery. Then, your assessment. They are tachycardic at 112 beats per minute and feeling lightheaded. And finally, your recommendation. I recommend a fluid bolus. Boom. This gives the doctor the exact nitty-gritty details they need to make a safe, rapid decision.
Which brings us to Section 4, Avoiding NCLEX Traps. All right, listen closely because we are officially entering the minefield. Trap number 1 is blindly copying previous charting. It is so incredibly tempting as a new nurse to just look at what the nurse before you wrote and repeat it, especially if you're second-guessing what you heard through your stethoscope. But you absolutely must avoid trusting the charting that came before you without doing your own independent assessment. To show you exactly why, consider this alarming yet honestly kind of absurd anecdote from the source material. A wound nurse was auditing charts and found that a previous nurse documented putting an ACE bandage on a stage 2 coccyx pressure injury. Think about that. A wound on the patient's backside. Medically, wrapping an ACE bandage around someone's pelvis for a pressure ulcer makes 0 sense. But because that first nurse charted it, 3 subsequent shifts of nurses just copied that exact same nonsensical note. Always, always do your own assessment. Let's rapid fire through a few other major NCLEX traps you need to avoid. Never pre-chart before an action. I mean, what if the patient refuses the medication after you've already documented giving it? Avoid vague charting. Keep your personal opinions entirely out of the medical record. Never use the chart to blame other staff or patients, and always avoid unapproved abbreviations. Just keep it strictly professional, guys. Look, mistakes happen, especially if you're working somewhere that still uses paper charts. But how you correct them really matters legally. Improper correction includes things like using whiteout or scribbling completely over the mistake so it can't be read. Don't do that. The proper, legally sound way to correct a written error is to draw a single line through the text so the original words are still completely legible, and then add your initials, the date, and the time. All right, Section 5, the incident report rule. This specific scenario trips up thousands of nursing students every single year. Let's say your patient has a fall, and you fill out an incident report, sometimes called an occurrence report. Here's the tricky question. Where exactly do you document that this incident report was completed? Think about that for a second. The answer is never in the patient's medical chart. The medical record is strictly for clinical facts. So after a fall, you chart the patient's condition, your assessment findings, your interventions, who you notified, and the patient's response. But you never ever document the existence of an incident report in the medical record. It is a massive liability trap and a guaranteed NCLEX distractor. And finally, Section 6, your final takeaway. As we wrap up this explainer, I want to distill all these rules into one ultimate standard. If you remember literally nothing else from today, memorize this checklist for safe, legally sound documentation. Chart what you observed, what you did, who you notified, and how the patient responded. Doing that covers your bases, ensures patient safety, and protects your license. I'm going to leave you with this famous, slightly provocative nursing thought. If you didn't chart it, did it really happen? In the eyes of the law, the hospital, and the NCLEX, the answer is definitively no. Treat your charting with the respect it deserves, and it will be your ultimate legal shield. Thanks for joining me on this explainer. Stay focused out there.
Okay, let's dive right into this explainer and uncover the fascinating, highly systematic process medical professionals use to read the hidden clues of the human body. You know, when we walk into a clinic or a hospital room, we often just see a routine checkup. But beneath the surface, there's an intense, structured investigation taking place. Because to actually solve the mystery of a patient's health, a nurse really has to act as a clinical detective. Literally from the exact moment they walk through the door, they're using their senses and specialized tools to gather crucial evidence. They are reading the subtle cues your body's giving off, long before any complex lab results ever come back.
So here is our game plan for today. We're going to break this investigation down into 4 steps. First, the assessment toolkit. Second, decoding the vital signs. Third, the 5th vital sign. And finally, number 4, the head-to-toe sweep.
All right, let's kick things off with Section 1, the assessment toolkit.
There's actually a very strict chronological sequence to how this physical investigation happens. It goes like this: looking, touching, tapping, and then listening. First up is inspection, using the eyes to check for size, shape, and symmetry. Next comes palpation, using the hands to feel for temperature, usually with the back of the hand, and testing for any tenderness. Step 3 is percussion, which is literally tapping the body like a drum to hear what's going on underneath. And fourth is auscultation, using a stethoscope to listen to the heart, lungs, and bowels.
But wait, there is one massive exception to that standard rule. When they are investigating the abdomen, the whole order has to change. A nurse must listen, or auscultate, immediately after looking, way before they do any touching or tapping. Why? Because if a nurse presses on the stomach first, they might accidentally move gas around and totally alter the natural bowel sounds, completely ruining the acoustic evidence. You literally have to listen before you disturb the scene of the crime.
Moving right along to Section 2, decoding the vital signs.
So understanding these normal adult baselines is absolutely key. We're looking for an oxygen saturation above 95%, a blood pressure somewhere beneath 120/80, and a heart rate between 60 and 100 beats per minute. But getting the respiratory rate, which normally sits at 12 to 20 breaths per minute, requires some serious stealth. Here's a brilliant little detective trick. Nurses will often secretly measure your respirations by keeping their fingers on your wrist pulse for an extra 30 seconds. Because if they tell you, hey, I'm counting your breaths right now, you're involuntarily going to alter your natural breathing pattern for sure.
Now, keep in mind, those physiological baselines change dramatically depending on the age of the patient. Just look at how the numbers shoot up for younger kids. Infants breathe significantly faster than adults. We're talking anywhere from 30 to 60 times a minute. And that makes perfect sense when you think about it. Their tiny, rapidly growing bodies demand a much higher metabolic energy output. They're constantly growing bone and tissue, so their lungs have to work absolute overtime to bring in oxygen and push out carbon dioxide.
But what happens when breathing goes off the rails? If a patient's breathing strays outside those normal ranges into severe dyspnea, their whole body basically moves as if it's fighting for survival. This is an immediate, glaring red flag for any clinician. They're looking for signs like nasal flaring, grunting, or the visible pulling of muscles between the ribs, which is called accessory muscle use. When you see a patient sweating and pouring every ounce of energy into just taking a single breath, you know their respiratory system is right on the verge of total exhaustion.
Okay, let's pivot to Section 3, the fifth vital sign.
Pain is widely considered the fifth vital sign. And to systematically decode a patient's pain without missing a single detail, nurses rely on a super handy acronym, OLD CARTS. They go right down the list. When was the onset? What's the exact location? Is the duration constant or does it come and go? What are the characteristics? Any aggravating or relieving factors? What treatment have you tried at home? And finally, what's the severity? This checklist ensures pain isn't just jotted down, but deeply, thoroughly investigated.
That characteristics question, that is a total goldmine for clues. By asking exactly what the pain feels like, a nurse can actually deduce the source of the agony. If someone describes an aching or throbbing feeling, that usually points to nociceptive pain, like standard tissue damage or inflammation. But if they describe shooting, burning, or tingling pain, that's a massive clue pointing straight toward neuropathic pain, meaning the nerves themselves are damaged or misfiring.
But here's the tricky part. Pain is completely subjective. You can't exactly ask a crying baby to rate their pain from 0 to 10. So nurses have to deploy different scales based on the patient's age and cognitive ability. For the tiniest infants, they use the CRIES scale. For toddlers, it's the FLAX scale, where they observe facial expressions and leg movements. Once kids hit about age 3, they can point to visual drawings on the FACES scale. And it's really only when a patient is 8 or older with full cognitive capacity that the standard 0 to 10 numeric scale finally comes into play.
Which brings us to what is essentially the golden rule of nursing. This is an absolute cornerstone of patient care. Even if a patient with chronic pain has completely normal vital signs, no elevated heart rate, no spiked blood pressure, their subjective report of pain must be treated as factual data. The body adapts to chronic pain, masking those usual objective signs, but a nurse's job is to assess and treat, not to judge the validity of what the patient says they're feeling.
Finally, we arrive at Section 4, the head-to-toe sweep. Armed with vital signs and pain data, it's time for the rapid, highly efficient physical sweep. Starting right at the top of the head, the nurse is hunting for vital neurological and circulatory clues. They scan facial expressions for any subtle drooping that could indicate a stroke. They check the eyes using the PERLA acronym, making sure the pupils are equal, round, and properly reactive to light. Honestly, this simple little flashlight test provides a direct, immediate window into the health of the patient's brain and central nervous system.
Working our way down, the assessment continues.
Inside the mouth, blue or dusky lips are an immediate siren for a lack of oxygen. On the neck, they palpate the trachea to make sure it's perfectly centered. They're also checking the sides of the neck for jugular vein distension, or JVD. If that jugular vein is bulging out, it's a huge red flag. It hints that the heart is really struggling to pump and the body is backing up with way too much fluid.
Moving down into the core of the body, the stethoscope becomes the star of the show. The nurse listens for the crisp lub-dub of the heart, hunting for any abnormal murmurs, and checks the lungs for crackles or wheezes. Then down to the abdomen. And remember, they are looking, then listening, before they feel. They're specifically checking to ensure there isn't a large pulsating mass, because a pulse in the belly could indicate an abdominal aortic aneurysm, or AAA, which is quite literally a ticking time bomb requiring immediate surgery. To wrap it all up, they check the plumbing and wiring at the very edges of the body, the arms, legs, fingers, and toes. Nurses use the PMS check, pulses, motor function, sensation, and capillary refill. They just want to ensure that blood is flowing vigorously all the way to the extremities and that the nervous system is successfully sending and receiving signals from the absolute furthest tips of the body.
So, as you can see, a clinical assessment is way more than just a random list of checks or a casual conversation. It's a highly structured, scientifically rooted investigation. From the strategic silence of measuring a respiratory rate to understanding the exact nuances of nerve pain, every single look, touch, and question serves a vital purpose. The evidence is always there. So, the next time a nurse walks into your room, what clues will your body be leaving behind?
Have you ever really stopped to think about how we track the exact physical math of the human body? Seriously, when a patient is lying in a hospital bed, they aren't just resting. They're a constantly shifting, dynamic mathematical equation of fluids, nutrients, and waste. If we aren't tracking exactly what goes in and exactly what comes out, we can easily miss the early silent signs of clinical deterioration. It is a fascinating, high-stakes balancing act. Welcome to this explainer. Today, we are embarking on a highly focused, high-energy journey through the physiological pathway of fluids and nutrition. We're going to look at the exact clinical rules for tracking a patient's intake, output, and elimination. We'll break down the crucial warning signs, the daily trends you absolutely need to watch for, and the hidden places the body loses or traps fluids. Okay, let's dive into this. We'll be following the natural in-to-out pathway of the human body today. Our agenda covers 1. Nutritional risk and swallowing, 2. Calculating intake, 3. Calculating output, 4. Bladder assessment, 5. Bowel elimination, and finally, 6. Why trends matter. Section 1. Nutritional risk and swallowing. Our journey begins right at the very beginning of the pathway, the moment a patient chews and swallows. Before we can even think about the nutritional value of a meal, we absolutely have to look at dysphagia, which is difficulty with swallowing. You really have to understand this clinical red flag. Swallowing difficulty isn't just a nutritional issue, it is primarily a severe safety problem. If a patient can't swallow correctly, food or fluid can slip right into their airway. This is known as aspiration, and it can rapidly lead to aspiration pneumonia. So how do we actually assess this risk? Well, it starts with the basics, obtaining height, weight, and a calculated body mass index. But we also have to dig into the lab values. Prealbumin levels are a massive clue here. The normal range is 15 to 36 milligrams per deciliter. If that number is low, it's a major indicator of malnutrition. And what happens if, during your assessment, you notice your patient coughs or chokes on even a tiny sip of water? You immediately make them NPO, meaning nothing by mouth. No food, no water, no medications. They stay strictly NPO until a speech-language pathologist performs a comprehensive swallow evaluation to safely clear them. Let's move along and see how this builds. Once a patient is safely cleared to eat, we don't just hand them a cheeseburger, right? We advance their diet in progressive stages. From strictly NPO, they usually move to a clear liquid diet, things like ice chips, water, ginger ale, or clear broth. Once they tolerate that, they advance to a full liquid diet, which includes thicker things like milk, pudding, and soups. If they need something easy to digest or still have mild chewing issues, they might move to a soft or pureed diet where everything has a very smooth, manageable consistency. Section 2. Calculating total fluid intake. Now that we know how food and fluids safely enter the body, we need to turn our attention to the actual mathematics of intake, because we need to account for absolutely everything entering the body. A super common trap is only counting the glass of water sitting on the patient's bedside table. But intake is so much more than that. Yes, it includes all oral fluids, but you also have to add in the volume of intravenous or IV fluids and any IV medications running continuously into their veins. And if your patient is receiving nutrition through a feeding tube, like an NG or G tube, all of that enteral fluid is counted as intake too. Literally, everything counts.
But listen, there is one very specific, absolutely crucial clinical rule you have to memorize when it comes to oral intake, and it involves ice. If your patient consumes a cup of ice chips, you cannot record the full volume of that cup. No way. You must record it as half, or 50% of its volume. Because ice is frozen and expanded, an 8-ounce cup of ice chips melts down to just 4 ounces of actual fluid intake.
And while we're talking about measuring things, you really need to remember your conversion factors. In the medical field, we calculate total fluid balance in milliliters. So you must memorize that 1 fluid ounce equals exactly 30 milliliters. It's that simple. If your patient drinks a 6-ounce glass of milk, you multiply 6 by 30 to get 180 milliliters of total intake. Section 3. Calculating output. We've mastered what goes in, so let's shift focus to the other side of the equation, how fluid and waste leave the body. If the intake doesn't match the output, we have a serious problem. Now, what's really interesting about this is that output includes some incredibly sneaky hidden things. Yes, the kidneys produce about 1 to 2 liters of urine daily, and we absolutely measure visible things like chest tube output or wound drainage, but the body also loses fluid in totally invisible ways, known as insensible losses. Did you know your lungs actually exhale about 300 milliliters of vaporized fluid every single day? It's true. And even without diarrhea, the GI tract loses another 100 to 200 milliliters. Throw sweating, a fever, or hyperventilating into the mix, and those invisible fluid losses dramatically increase. Section 4. Bladder assessment. Since the kidneys are responsible for the vast majority of our visible fluid output, let's look really closely at the bladder. Think of the kidneys as the body's ultimate washing machines. They filter the blood, remove the waste, and send it straight down to the bladder for elimination. Because they are so incredibly vital, you must memorize this absolute red flag threshold, the 30 milliliter rule. If a patient's urine output drops below 30 milliliters per hour, you have to sound the alarm immediately. This suggests severe alluria, meaning the kidneys just aren't producing enough urine. It could point to extreme dehydration and obstruction or impending renal failure. Basically, toxins are building up inside the body instead of being washed out. When assessing the bladder, we also have to bust a really common medical myth. We have to clearly distinguish between urinary retention and urinary incontinence. Retention happens when the bladder fills with urine but completely fails to empty properly, causing painful distension. Incontinence, on the other hand, is the involuntary leaking of urine. But here is the trap. Just because a patient is incontinent and leaking urine does not automatically mean their bladder is fully emptying. Actually, a patient can have severe urinary retention and still experience what we call overflow incontinence. To truly know what's going on in the urinary tract, we often need to grab a clean catch urine specimen. Getting this right is absolutely critical so we don't accidentally contaminate the sample with bacteria from the surrounding skin. The exact progression goes like this. First, thoroughly clean the urethral opening, making sure to wipe from front to back for patients with a vulva. Next, the patient begins urinating directly into the toilet. Then they stop and collect the midstream urine in the sterile cup. Finally, they finish urinating in the toilet. Catching it midstream like this gives us the purest, most accurate look at what's actually inside the bladder.
Section 5. Bowel elimination.
Let's move further down the GI tract to discuss our other major form of output, bowel elimination. Tracking these daily patterns isn't just basic care, it's a fundamental nursing duty that protects the patient from massive risks. For instance, certain medications like opioids and NSAIDs, combined with being stuck in a hospital bed with low mobility, create the absolute perfect storm for severe constipation. As an intervention, studies show that simple, non-invasive techniques like abdominal massage can actually improve bowel function without immediately resorting to harsh laxatives. But pay attention here. If a patient hasn't had a bowel movement for several days, it requires immediate clinical assessment. You aren't just looking at constipation anymore, you're looking at the potential for a highly dangerous small bowel obstruction.
Section 6. Why trends matter.
We've tracked the intake, the bladder, and the bowels. Now we have to bring this all together into the big picture to see why these daily trends matter so much. And this brilliantly illustrates what happens when the 24-hour balance tips way too far toward a deficit or an overload. On one side, if output dramatically exceeds intake, you get deficient fluid volume. You'll see dehydration, dry mucous membranes, and elevated BUN levels in their blood work. On the exact opposite side, if intake is way higher than output, you get fluid volume excess. This leads to rapid weight gain, fluid pooling in the tissues, which we call edema, and severe risks to the heart and lungs as they struggle to pump all that extra fluid around.
When assessing for these imbalances, you have to be incredibly careful. It is a huge clinical trap to just assume that a dehydrated patient will simply ask for water. Thirst alone is not an adequate hydration assessment. This is especially true in our elderly patients. You see, as we age, our natural thirst mechanism naturally diminishes. An elderly patient could be dangerously dehydrated with terrible urine output and high lab values and still confidently tell you they aren't thirsty at all. So, the crucial point is this. If you cannot rely on thirst, what's the best way to track overall fluid retention? Well, it's the scale. Taking a patient's daily weight is one of the single most useful indicators of a fluid balance change. If a patient rapidly gains 2 or 3 pounds literally overnight, they didn't suddenly put on muscle or fat. That rapid weight gain is entirely retained fluid. We've seen how absolutely vital it is to monitor everything from swallow safety to hourly urine output to daily weight trends. So, as we wrap up, I want to leave you with a provocative question to really test your clinical instincts. If you calculate a patient's 24-hour balance and their fluid intake is drastically higher than their output, but their bladder isn't full and they're urinating, where exactly is all that fluid hiding in their body right now? Think about the lungs, the tissues, and the vascular space. Uncovering that answer might just save their life. Thanks so much for joining me on this explainer, and remember to keep tracking those trends. We're going to explore the intersection of the classic nursing process and the newer clinical judgment measurement model, or the CJMM. If you've ever felt like textbook theory doesn't quite match the rapid-fire, chaotic pace of a real hospital floor, you are absolutely in the right place. Okay, let's dive right into this. Picture this. You're on the floor, you've got your care plan meticulously written out, but suddenly your patient's condition just rapidly deteriorates. So what happens when a patient's condition changes faster than your care plan? Well, real life doesn't exactly wait for you to sit down and write out a new diagnosis, right? In high-stakes, fast-moving clinical emergencies, you need a cognitive framework that can actually keep up with reality. Section 1. The Nursing Process Foundation. To understand where we're going, we first have to validate where we come from. Let's look at the foundational knowledge you already possess. The classic, highly reliable nursing process. I mean, this is the literal cornerstone of patient-centered care. We all know the mnemonic ADPIE. Assessment, diagnosis, planning, implementation, and evaluation. Historically, this has acted as a sequential, step-by-step ladder. It's a fantastic, systematic, critical thinking model established by the American Nurses Association. You climb this ladder one step at a time to create a clear roadmap for patient care, making absolutely sure you don't miss anything, and of course, minimizing errors. Let's briefly ground that first crucial step, assessment, in reality. When you assess, you're gathering both subjective and objective data. Subjective data is what the patient directly tells you. Like, my hands itch so bad I can hardly stand it. It's their perspective, totally unmeasurable by a machine. Objective data, on the other hand, is reproducible and measurable. We're talking vital signs, laboratory results, or daily weights. Actually, really quick side note here, and this is a huge takeaway. Daily weights are the absolute best objective indicator of a patient's fluid status. Way, way more reliable than just checking their intake and output. Section 2. Real-time care demands the CJM. But here is the plot twist. While ADPIE is incredible for care planning, actual clinical practice is, well, pretty disruptive. Emergencies simply do not wait for you to finish one step before starting the next. Real-time care demands something much more dynamic. So why is this shift happening now? The National Council of State Boards of Nursing, the NCSBN, went out and spoke to industry leaders and employers, and the feedback they got was urgent. They found that entry-level nursing students were lacking clinical judgment, which consists of real-time critical thinking and decision-making. Essentially, new nurses were amazing at writing care plans, but they were really struggling to think on their feet when a patient actually crashed. In this comparison brilliantly illustrates the core difference. Think of it as a ladder versus a loop. ADPIE is your ladder. It's sequential, it's linear, and it's highly focused on care planning. You finish a step, you move up a rung. The CJMM, however, is a loop. It is layered, continuous, and entirely focused on real-time decisions. It requires you to be analyzing while you're acting and adjusting while you're evaluating. You're not waiting to finish documenting a diagnosis before you take action on a crashing patient.
Section 3. Connecting ADPI and the CJMM. Now, I want to reassure you right now, this new model does not discard what you already know. It doesn't replace ADPI, rather, it elevates it. Here are the 6 cognitive layers of the NCSBN Clinical Judgment Measurement Model. Step 1, recognize cues. 2, analyze cues. 3, prioritize hypotheses. 4, generate solutions. 5, take action. And 6, evaluate outcomes. It's this beautifully continuous, flowing loop of clinical thinking happening at every single point of patient care.
Now, what's really interesting here is how perfectly these two frameworks map onto each other side by side. Assessment becomes recognizing cues. Diagnosis translates to analyzing cues. But look closely at planning. Under the CJMM, the planning phase actually splits into 2 distinct active steps: prioritizing hypotheses and generating solutions. Implementation is taking action, and evaluation is evaluating outcomes. See, you already know the foundation. We're just refining how you process it in real time.
To really master this, we have to look at the underlying science of how nurses think, specifically inductive reasoning. And let's be honest, this is how you as a nurse instinctively think anyway. Inductive reasoning involves noticing cues, making generalizations, and creating hypotheses. It's exactly like gathering pieces of a giant jigsaw puzzle. You notice a cue that falls outside expected findings, you organize those cues into a pattern, and boom, the whole picture becomes clear. Only then can you form a solid hypothesis about the why behind the problem.
Section 4, Clinical Judgment in Action. All right, let's put you directly into the scrubs for a real-world scenario so we can see this clinical judgment in action. Here's your scenario. Your patient just had surgery. Suddenly, out of nowhere, they become short of breath. You look at them, their respiratory rate is rapidly rising, and they look incredibly anxious and restless. This is a fast-moving clinical emergency. If you stick strictly to the ADPI ladder, you might stop and try to formally diagnose the patient before acting. But like we said, life doesn't wait. So the absolutely crucial point here is how you filter this through the CJMM loop instantly. First, you recognize the cues: shortness of breath, dropping oxygen. Then you instantly analyze those cues. Could this just be post-op pain? Is it anxiety? Or wait, is it a pulmonary embolism? You quickly prioritize your hypotheses. A pulmonary embolism is life-threatening, especially post-op, so that's your top concern. You don't wait around, you generate solutions and take action immediately. Raise the head of the bed, apply oxygen, and get the provider on the phone. You are literally thinking, prioritizing, and acting simultaneously.
Section 5. Preparing for the NCLEX. Now, let's transition to the practical application of these frameworks for nursing education. How does all of this impact you when you finally sit down for your licensure exams? Well, the magic number here is 6. And seriously, don't let this intimidate you. When you take the next generation NCLEX, the case studies you encounter will feature exactly 6 questions. And guess what? Those 6 questions directly and sequentially follow the 6 cognitive skills of the clinical judgment measurement model we just mapped out. You literally cannot evaluate the outcome before you recognize the cues. The exam is simply testing your ability to loop through these exact cognitive layers. So we've broken down ADPI, we've explored the dynamic loop of the CJMM, and we've seen how they map perfectly together to save lives in real time. I want to leave you with this final provocative thought. How will you adapt your thinking from a ladder to a loop for your very next clinical shift? How will you actively engage your clinical judgment the next time you step onto that hospital floor? Thank you so much for joining me for this explainer. Keep analyzing, keep acting, and I will see you next time.